introduce Dr. Jonathon Dutton, who Dr. Buckley mentioned. They had done research on botulinum toxin since the 1980s. And before he went to medical school, very interesting, he trained at Harvard, and he was a vertebrate paleontologist. So he has this extreme knowledge of anatomy. He's written some of our very best anatomy textbooks. He's been the editor of our journal for 15 years. And he's worked here at UNC, and now he worked at UNC and Duke. And we're just so thankful that you're here and you can share this amazing fund of knowledge. And he is one of the best lecturers for facial anatomy, everything we've ever asked him to speak on. He's incredible. So please come up, Jonathon.
Okay, so I'm going to talk about facial movement disorders from the perspective of the oculofacial specialist. Oculofacial specialists are ophthalmologists who deal with disorders and diseases of the eye, the space behind the eyelids, the brows, and the mid-face. So from our perspective, the things we're most interested in are the clinical symptoms that patients present with, the etiology or the cause of those specific spasms that we see, management strategy, and the evaluation of the treatment outcomes. How good are the treatments? There are lots of causes of facial spasms that we see. This is just a list. The ones that are most important to us are essential blepharospasm, hemifacial spasm, and what's been called apraxia of eyelid opening, which is a misnomer. It's not an apraxia. It's a special form of dystonia, much like the rest of blepharospasm. Okay, so blepharospasm are involuntary contractions of the eyelid muscles, and it can be reflex, secondary, or primary. So there are three basic types. Reflex blepharospasm are due to eyelid or facial irritation of the eyes, such as dry eyes or things touching the eye. The most common causes blepharitis, where there's inflammation of the lid margins and you have secondary spasms, touching eyelashes that are misdirected and touching the eye, or lids that are turned in, rubbing against the eye. Iritis, so this little kid has inflammation of the eyeball itself, and then reactive spasms of the eyelids. And corneal abrasion, scratches on the surface of the eye or even a foreign body on the cornea. All of these things can cause reflex spasms. Obviously, the treatment is not the spasm, but of the initial cause. If you clear that up, then the spasms will typically go away. Secondary blepharospasm are related to structural lesions, brain lesions, especially in the midbrain and the region of the basal ganglia. They can be caused by tardive syndromes due to as a secondary effect of some antipsychotic medications, and can be associated with some neurodegenerative diseases such as Parkinson's disease. Primary blepharospasm, which is primarily what we're talking about, is a neurologic movement disorder classified as a focal dystonia. I'll talk about that in a second. These are abnormal involuntary muscle contractions they cause repetitive and sometimes sustained contraction of the muscles. And dystonias, there are lots of classification of dystonias, but for our purposes, they can be focal, where they involve a single body part, such as the eyelids. They can be segmental, where they involve two adjacent parts, such as the eyelids and the mid-face. And they can be regional, where they involve three or more body parts adjacent. So eyelids, mid-face, maybe cervical dystonia or the vocal cords. So this is a kind of a classic definition of primary blepharospasm. A chronic, variably progressive, bilateral, so it involves both eyes, synchronous, so both eyes are doing the same thing at the same time, involuntary focal movement disorder, characterized by mild to forceful contraction of the eyelid closing muscles. The muscles involved involve the procerus, the depressor supercilii, the corrugator muscle, and the orbicularis oculi muscle, the major muscle that causes closure of the eyelids. There are some potentiating factors that sometimes initiate the spasms or make them worse. Things like bright lights, which is maybe the most common, watching television, reading, stress, driving, all of these things have been described as initiating the spasms. It's more common in females than males, in a ratio of somewhere between 2 and 3 to 1. The age range reported in the literature is from 3 weeks of age to 93, but for the most part, it involves patients between 55 and 60 years of age as the onset of the disorder. The prevalence in the United States, that is how many cases we have right now, according to the literature, somewhere between 50 and 130 cases for every million people in the country. So that's somewhere between 17 and 43,000 cases that we have in the United States. The incidence, how many new cases are diagnosed every year? Between 6 and 7 for every million people in the country. So that's up to 2,300 new cases diagnosed every year. Keep in mind that these data in the literature are based on patients who are currently being treated. And so there are patients who are affected for months or years before they're actually diagnosed. So the actual incidence and prevalence are probably higher than reported in the literature. The manifestations, they can begin on one side in up to 20% of patients, but it always becomes a bilateral disease involving both sides. It usually begins with just an increased frequency of blinking, and then ultimately progresses to intermittent and then sustained forceful contractions that can lead actually to functional blindness. These patients have difficulty performing common visual tasks without having to hold their eyelids open, as I see some of you doing. In the old days, we don't use these anymore, but we used these crutches on the eyeglasses for patients with droopy lids to hold their lids up. In cases with mild blepharospasm, sometimes that worked, and we used to use that sometimes. But these days, I haven't seen crutches on glasses for many decades. Or the patients can use tape to hold their lids up, as you see in the lower frame. As with many dystonias, blepharospasm patients often use what's called alleviating maneuvers, things that can lessen the degree of the spasms or the intensity. And these can be reported in about half the patients with blepharospasm report that they actually use these. And these can be touching the face or the brow, opening the mouth, singing, chewing gum, things of this sort. And there's one study in 1999, actually that was with spasms of the neck muscles, torticollis, and they showed that in 75% of these patients, EMG, the electrical activity in the muscle, actually decreased during these alleviating maneuvers. Between 50 and 70% of patients with blepharospasm will progress from one focal area, the lids, to the next focal area, mid-face, and then sometimes to the next focal area on the neck. Those who are going to progress, 85% progress to the mid-face, 45% to the cervical muscles, and 10% to the laryngeal muscles for affecting speech. Those who are going to progress, about 20% do so within the first year after the onset of the disorder, about half within the first 2 years, and most of them will do it within 5 years. There are some risk factors that have been identified that might be related to the risk of progression, and that is a family history of other dystonias or older age at onset of blepharospasm. There are other risk factors that have been identified in patients who are genetically predisposed. They may be predisposed to develop blepharospasm but may not have it yet. 50% of patients who develop blepharospasm had a prior history before they developed the disorder of dry eyes, blepharitis, conjunctivitis, iritis, corneal disease, and photophobia, especially light sensitivity. And 72% had a stressful event before the onset of the blepharospasm. Things like depression, anxiety, panic attack, death of a family member, or even surgery on themselves. So patients with these risk factors have an average onset of the disorder between 3 and 6 years earlier than the average for the disease. So they seem to develop it sooner. You've all heard of Meige syndrome, so I thought I'd include this. In 1910, Henry Meige described a condition of a patient who had spasm of the eyelids, the midface, the jaw, the muscle, the lingual, and the neck, all in one patient. And in 1972, another person, Paulson, described 3 more patients with similar characteristics, and he honored Meige by calling this Meige syndrome. You've all heard of Meige syndrome. However, the same condition was described in Europe in 1870 by Talcott and in the United States by Horace Wood in 1887. So if you're a nomenclatorial purist, which I tend to be, following the rules of nomenclature, this should not be called Meige syndrome, it should be called Talcott syndrome. But what is Meige syndrome? It's simply a segmental dystonia. So it's gone from a focal dystonia to a segmental dystonia consisting of 2 focal dystonias, Blepharospasm and oral mandibular dystonia. That's what it is. And so the term segmental craniocervical dystonia has been proposed, and perhaps a better term might just be blepharofacial dystonia. At least it describes it. I hate eponyms with people's names because I never remember what they mean. But if you use something that's descriptive, at least you know what they're talking about. Okay. Pathophysiology, what causes it? Well, there are a lot of ideas, and it's really not completely understood. It's certainly a neuropathologic condition, but we don't really understand all the details. The evidence suggests that the basal ganglia in the midbrain is, at least in part, dysfunctional, and also recent evidence suggests that higher neural elements are involved, the cerebellum, the brain stem, as well as the cerebral cortex and the basal ganglia. The treatment options, which you're going to hear about today in other talks, for symptom, darkly tinted glasses for the light sensitivity, which is so common in this disease, artificial tears to reduce the sensory input from irritation of the eye, neuromodulation, you're going to hear some talks about that with some promising results, chemodenervation, which right now is the frontline treatment, which you heard about from Dr. Buckley with botulinum toxin. And then for patients who are refractory to these, we have surgery that we can resort to, myectomy, blepharoplasty, and brow suspension. So in conclusion, blepharospasm is a very variable movement disorder. There's no cure for the condition, but there are a number of different treatments that are available. No treatment is completely effective in every patient, so you have to try them. And all treatments have to be individualized for the individual patient. Thank you.